We're going to start off the session in a few moments, but first I'd like to introduce my panel. We have Dr. Andrew Holden, Dr. Matthew Menard, Dr. Robert Schainfeld, Sabine Steiner, Christopher White, and Dr. Luke Wilkins, all on the panel. We'll begin the first presentation with Dr. Dan Clair, who will be discussing the two-year outcomes from the PROMISE-2 trial of transcatheter arterialization of deep veins. Dan?
Thanks, Brian, and again, thanks to the organizers for allowing us to present this data as I'm doing it on behalf of the PROMISE-2 investigators. We know that up to 20% of patients with critical limb-threatening ischemia have difficult distal revascularization options, and for many of these patients with this severe disease, death or amputation in more than half is an ultimate outcome. Transcatheter arterialization offers an alternative for these patients, and this presentation includes the two-year outcomes from the PROMISE-2 trial, which is really the largest study of long-term outcomes in these patients. The study was done utilizing LimFlow's transcatheter arterialization system. It's the only FDA-approved device and leverages the healthier veins that are in the leg as a conduit to create a new route to delivering oxygenated blood to the distal tissue in the limb. It has an integrated system for arteriovenous crossing that you see on the bottom left, an antegrade over-the-wire valvulotome, which you see in the middle, and stent grafts, which allow diversion of flow from the arterial system into the more distal venous system. These are the types of angiographic images that you'll see in these patients: poor distal perfusion, no real option for surgical bypass or intervention in these patients, and many of these patients with significant tissue loss when they were enrolled. And these are, on the right, you see the outcomes of a typical transcatheter arterialization procedure and what this looks like somewhat down the road, and you can see what you can achieve for these patients in terms of wound healing and ultimately maintenance of their ability to ambulate. The PROMISE trials are a series of trials that were done that were single-armed studies to assess the performance of this technique and this technology in a multi-center way. PROMISE-1 was an early feasibility study done at 7 centers that enrolled just over 30 patients and looked at amputation-free survival at 6 months. PROMISE-2, multi-center prospective, again, 20 centers, 105 patients. The primary endpoint was amputation-free survival at 6 months, but we'll be presenting amputation-free survival at 2 years now. PROMISE-3 is still enrolling. The goal is to enroll 100 patients and to look at the same primary composite endpoint. And you'll see some information from Clarity as well, which is probably the largest collection of no-option patients who were not enrolled into this type of trial. The PI for the PROMISE-2 trial were myself and Mehdi Shishabur, a cardiologist in University Hospitals in Cleveland. On the bottom left, you see the key eligibility criteria. Critically, there was a committee who evaluated these patients made up of interventionalists and surgeons who assured that there was no option for revascularization. 105 patients at 20 sites. There were no roll-in patients, so this really was an initial experience for a number of the investigators performing these procedures. These are the procedures, and the outcomes really are the results of their efforts on behalf of these patients. Baseline characteristics in the population you see on the left. These were older patients, a very high prevalence of diabetes and hypertension, and about 20% of the patients had end-stage renal disease, severe kidney disease in almost 40% of patients. Most of these patients were Rutherford 5 and had significant wound areas with very high Wi-Fi scores. This is the 2-year limb salvage that you can see out in the PROMISE-2 group. It was 69% at 1 year, 65% at 2 years. This is wound healing status. 82% of the patients were either healed or healing at 2 years. but there are a group of patients who continue with the wound, unfortunately, even out to 2 years. Pain scores, which can initially go up in this group of patients, was dramatically improved over the time of the study. The PROMISE 1 and 2 trials, really you see the patients were a very similar group of patients, and when you combine these two studies, which really had the same inclusion and exclusion criteria, except that PROMISE 2 included a group of patients with end-stage renal disease who are on dialysis. These outcomes have both been published in peer-reviewed journals. You see here the limb salvage, the survival, and the amputation-free survival from PROMISE 1 and 2. Survival overall of just over 70%, limb salvage closing in on 70%, amputation-free survival just about 50% in this group of patients. When you look at limb salvage and you compare limb salvage to those patients who really had other alternative strategies tried, you can see that there's a significant survival advantage for the patients who are able to have venous arterialization that is sustained out to 2 years. And in every group, there was a benefit to their outcomes with venous arterialization. When you look at amputation-free survival, again, this is PROMISE 1 and 2 versus Clarity, you can see a marked improvement, almost a doubling of the amputation-free survival in these patients at 1 year. And again, these are a very sick group of patients, so there is some survival loss between year 1 and year 2. If you combine PROMISE 1 and 2 and look at wound healing and pain, the outcomes are very similar. There's still very good wound healing out to 2 years in this group of patients, and very low pain scores ultimately after the 3 to 6 month time point in these patients as well. In conclusion, then, there's sustained limb salvage outcomes through 2 years, despite the inclusion of very sick patients, including those with dialysis. This is currently the only approved device for treatment of this disease. LimFlow has been included in 2024 multi-societal guidelines, and PROMISE 3 continues to enroll patients. Improved wound healing, better survival, and improved amputation-free survival were all noted in this and have been published extensively. Thank you.
Thank you, Dan. Nice presentation. I'll open up to the panel for any questions for you. Maybe I'll start off by asking you about extending this to patients with rest pain. Do you have any thoughts on that and comment on that? And the reason I ask is because that seems to be a metric that clearly has improved in almost all categories for those patients undergoing this procedure in both PROMISE 1 and PROMISE 2. So do you have any thoughts on whether or not this is a long-term solution for some of those patients? Because often we have no other real good options that are durable for them.
So I have personally done this procedure, not with the LimFlow technology, but I have done this in patients before the device was approved. And the fact is, it does provide relief, but there is risk of forefoot loss. I didn't discuss this, but in the PROMISE 1 and 2 trials, about 35% of patients wind up with a transmetatarsal amputation. It's still a walking amputation, but it is difficult to have patients who have rest pain and submit them to this. Now, many of the patients who wound up with transmetatarsal amputations started with severe wounds of the toes, and I don't think this would have been avoidable even with an arterial reconstruction had it been feasible. But there is the potential for the toes to worsen after venous arterialization. That's one of the things I think we have yet to solve.
Dan, congratulations. You mentioned that, for some of these sites, it was early in their experience, and one of the things I think globally we're appreciating is the need for surveillance and reintervention. So maybe you could comment on what kind of surveillance and reintervention happened in this trial and what you're thinking about how that's evolving.
So for the study, we actually did duplex at 1, 2, and 3 months. I think their protocol required 1 and 3 months, but many sites were doing duplex ultrasound with flow volumes at the first, second, and third month visit. For most of these patients, if you get them through that 3-month period, they actually will do remarkably well and will heal really well. If there is too much flow or too little flow, you may have to intervene, and part of that may be directing or diverting blood flow to further out in the forefoot. Part of that may actually be treating either an inflow or an outflow lesion to maintain the circulation through the deep vein arterialization.
And can you comment on what percentage of patients require those repeat interventions after the initial DVA?
So that's a great question. I think the number is about 35 to 40% will require some reintervention through the first year.
Great talk, great results. Kind of a question that kind of builds on the questions already asked, but patency, certainly relevant to tackling any rest pain patient and recurrence. And, you know, it's all sort of swirling. How many stay patent? And if you're thinking about long-term results and preventing recurrence and treating rest pain, what are the thoughts there? The relationship between patency and long-term?
So it is interesting. And I mean, Matt, we've talked about before the fact that this is not like other revascularizations. Many of these will fail within a year. Despite that, there is clearly a distinct new arterial blood distribution that develops in the foot. The first several patients I treated all failed within a year and all retained their limbs for the entire time they were alive. One, at least 5 years out, was claudicating in the other leg. I don't understand it completely. It's part of the issue I think we have yet to discern about this, the mechanism by which that occurs. But there clearly is some angiogenesis, possibly some recruitment through alternative pathways to get blood flow into arterioles that were not patent or were hibernating before. There is probably a number of mechanisms that explain what happens in this group of patients.
Maybe I'm wrong, but I think the number at risk was pretty low at 2 years. I think it was 38 patients or so. Is that highlighting that the patients are really also complex with respect to compliance coming back to follow-up, or is there any special reason for that?
So I think a lot of that reflects just the illness that these patients have overall. I mean, the survival in these patients is about 50% at 2 years. I think we're really defining a group of patients where it's great for them to keep their limb, but we need to do more to help them with their overall survival. Some of it is because of follow-up is difficult for patients with dialysis and in addition, severe peripheral vascular disease. But this has an impact on survival, but there's a lot more that we have yet to do that will improve that further.
Bit of a pledge or outreach. I don't know if you guys remember Jeffrey Isner back in the late 90s, early 2000s, rest in peace, but therapeutic angiogenesis, perhaps in concert with this, I wonder if that might be something that could ever be resurrected. Unfortunately, Jeffrey met his maker, but really intriguing the concept of VEGF, perhaps angiogenesis in concert with endovascular, something, same substrate we're looking at on, not good substrate for any intervention.
I think anybody who's done this and has looked at angiograms down the road in these patients clearly has seen evidence of angiogenesis that's occurring in these patients. There's clearly something that's going on that is beyond just retrograde flow through the capillaries to provide oxygenation.
All right, sounds good. Thanks so much, Dan.